Hi, my name is Mr. Ray O'Sullivan. I'm a consultant senior lecturer in the Royal College of Surgeons in Ireland. I'm also one of the directors of EndoSim, and with my colleague Professor Walter Prendeville have had the pleasure of developing what is becoming a widely used technique for laparoscopic surgical skills training. And with respect to this, we've formulated a talk here just to explain to you how maybe what we've been through here in Ireland, in the UK, in Australia, in the Middle East, can help you guys with respect to laparoscopic skills training in Nigeria and West Africa. I suppose the core belief, the core tenet of our course is that we are what we repeatedly do. Excellence then is not an act, it's a habit. So as long as 4,000 years ago Aristotle realized that what we repeatedly do becomes habit, and we kind of have that philosophy at the core of our course. Historically, what has happened over the last 30 years has been that as experts around the world developed expertise with respect to laparoscopic skills training, they were invited to our hospitals to demonstrate how good they had become at various procedures. These faces and these names like Ray Gary, Chris Sutton, Peter O'Donovan, Kurt Sem, Harry Rich, all names that are familiar to us and names of people that came to visit with us in our hospitals. And we were very enthusiastic about their arrival and their time with us. But what we really did was we figured out how good these guys were. We realized pretty quickly that we could never emulate them. Things didn't always go well in the operating theatres, and I think a lot of people were put off by what they saw. But a few remained enthused, and I suppose they're the vanguards in our own hospitals and our own countries, and they have continued to push on with lap skills training. Following these visits by the masters, short courses were designed to help develop skills. And these have been proven to be quite useful, and this is where we're at pretty much today, that short courses is how we teach most skills to our trainees. But the skills acquired are not often practiced on an ongoing basis. There's no persistence with these skills. They're quickly forgotten, but many remained enthused following them, and people like myself who had done these courses and also underwent my surgical training went on then to employ these techniques in my own practice and went and did an advanced fellowship in them. So I think they weren't wasted, but at the same time they are not the entirety of lap skills training. Animal laboratories, many people say to me, well, animal laboratories are where you learn your skills, but no, it's not. I think animal laboratories are expensive, and they're probably only useful for those that already have the skills. And also legislation in various parts of the world make animal laboratories difficult to organize and get licensing for. Then came along virtual reality and augmented reality, and there was a lot of hope with these systems, but they haven't proven to be very worthwhile. We ourselves purchased 2 VR systems for assessment during some of our research, and I think that's all we really use them for, is assessment. We don't use them as a tool for teaching. And the problem with them is that, well, they are expensive. There aren't many of them about, and there isn't any haptic or feedback with respect to the tissues and what you're seeing and doing. Other challenges face us all. In Europe especially, we have the 48-hour work week, which is proving challenging with respect to delivery of skills training. We also have increased the number of trainees as a consequence of this, so there is a dilution of experience. Also, the trainers, in other words the consultants of today, have less experience than the consultants of the past, so their ability to teach their trainees is less. And unfortunately, the apprenticeship model, the Halstead model of training, is now consigned to history. What I'm saying there has been borne out in research. One of my research fellows has looked at over 30 years of surgical workloads in Ireland, and there's been a dramatic fall off in things like hysterectomies, and many of us would have expected a hysterectomy a week at least as a trainee. For many of our trainees, that's down to maybe 3 or 4 a year. So our ability to deliver training in the traditional model has now gone. When I came back from Australia following 4 years of fellowship training there, I got together with Professor Prendeville, who was one of my mentors during my early days of training. And we got together and we formulated a course which had two main core elements to them: didactic or lecture-based teaching, plus also skills training. And to keep costs to a minimum, we designed our own simulators. And we also designed our own training jigs and platforms. We partnered with our industry colleagues, and they gave us the instrumentation required. And we ran very successful courses, and at times we ran it for an extremely large number of trainees. And in fact, so successful was the course that many of our consultant colleagues came along as well. And you can actually see here where we actually managed to fill a room with 20 or more simulators and trainees and some consultants. In fact, professors and masters from our hospitals have come on these courses. So today, this is our course. It works extremely well. A lot of trainees in Ireland have now come through this system. This is actually our old course, but just to show you, we ran it in a room. We didn't need much facility except for PowerPoints. That's all we needed. You just need power, two plugs for each simulator. We ran the talks in the middle, and we just ran that out of, in fact, that was Walter's office, Professor Prendeville's office. We converted it over to deliver training. As part of this, we teach people how to make the jigs. We have videos up online. This, for example, is an ectopic model being made by one of our fellows. I let that run because it's just, I think many people that see it kind of think it's just the most simple thing, using Play-Doh, our modelling clay that children use for playing, and make your own model of bilateral ectopics, and you get to do two ectopics in the one model, which costs nothing, and it's covered just with clear plastic sheeting, and it's put inside in the simulator. This shows how to make ovarian cysts using balloons and some glue, and these work extremely well. And this then is what it looks like inside the model situation. And I think if there was anything I wanted to achieve coming back to Ireland, or myself and Professor Prendeville want to achieve, it was that we would someday be able to have all women in Ireland being dealt with laparoscopically if they had an ectopic pregnancy. And actually that has come to pass. So the core fundamentals of our course is that the training is take home. The simulator is brought home by the trainee, or at a minimum that the trainee has regular, frequent encounters with their simulator. We also have internet backup. We use a virtual learning platform called Moodle to be able to upload our videos and our lecture content. We see our trainees every month, and we assess them on a monthly, ongoing basis. We emphasize the use of non-dominant hands. We emphasize repetition. And as an incentive at the end of the course, we have our Laparoscopic Olympics. And I think someday I would like this to be maybe something that will happen globally. Then our trainees from around the world will get together for competitions, maybe in association with some of our international meetings. The curriculum, broadly speaking, is divided into two areas. We tend to emphasize ergonomics, the use of instrumentation, troubleshooting the instrument stack, the stack when there's difficulty, how to deal with ectopics, cysts, endometriosis, and hysterectomies. And the skills we teach are from the very basic, the use of the camera, how to manipulate and orientate the camera, right the way through to suturing. And as I said, this course is very robust, and all our trainees who've been through this course really enjoy it. It's also worth saying maybe at this point that our surgical colleagues have also come on board with this, and our current course involves our surgical colleagues and surgical trainees. So over the last number of years, we've now got a home for our course. We have a couple of homes for our courses, with the trainees bringing and taking away the simulators, but we have fixed monitors or fixed televisions, because that's all you need is just a cheap television screens, and we have those fixed on arms in one of the teaching hospitals. This just shows the course in action. This is Professor Prendeville giving a lecture. It generally does not take a lot of effort or work from the trainers on a day, those that are delivering the training. Work has to go in beforehand in the preparation, but during the day the trainees work in pairs, and we can tend to give them one-to-one training, even with 2 or 3 of us present. The course is very transportable. This is Robert Bailey, one of my colleagues, and he's present at a course which was run in Bournemouth in the UK. So we can quite easily move the course to any location, as I said, where there's PowerPoints, and trainees can bring their simulators with them. Or if an organisation in Nigeria or West Africa wanted to take this on board, they could be bringing these to various locations to deliver training. But as I said, and I re-emphasise this, it's important that the trainees have easy, ready access to their simulators, and preferably that should happen at home. The London Deanery, there's 1,200 trainees in London, surgical trainees in London, and they have our simulators in St Thomas's and Guy's in London, and based from there they're running courses now, and there are plans to run this course up and down the UK next year. The course also has now been run in Sydney, and I had the fortune of recently going back to my colleagues, my bosses in Sydney, and they've now adopted the same course. And this shows some of the trainees in Sydney, and also with a colleague of mine in Saudi Arabia, we're now running the course, and we have supplied distance learning to our colleagues out there, and I've delivered lectures during their courses there. As I mentioned earlier, we do have partners in industry, and we ask them to deliver some of the course content. This is one of our colleagues who's an electrosurgical specialist, and he has talked about the use of electrosurgery, and actually we get them back in at the end of the course for the Laparoscopic Olympics, where we set up an operating theatre and we create faults with the electrosurgical generators, and also in the stack and the image on the screen. So we create problems there, and our trainees should at the end of the course be able to sort those problems out. So this is where we've come to. The course is very enjoyable, it's widely subscribed, we've never actually advertised our course, and we continue to fill it up everywhere it's brought. There is ample opportunity for training, but I think also the course is designed in such a way that it can be profit making, so that the profits can be redeployed back into further development of the course and buying new equipment. More recently, as I said, we've partnered with our colleagues in the Royal College of Surgeons, and this is our most recent course up and running, and you can see with just tables and camera arms we can mount the screens and create simulators very quickly anywhere. All you need is seating for some lectures in between the skills training, so it works extremely well. Again, this is Professor Prendeville giving a talk at our most recent course. But one thing that we've actually introduced now is the FLS course from the US, and we're now assessing that with respect to our trainees. So if anyone does our course, we'd expect them to be able to pass the FLS program that SAGES in the United States rolls out. We start with the basics, as I said. This is just a simple camera exercise. We show them via lectures how to do open laparoscopy and closed laparoscopy. These are the simple training exercises, learning to manipulate objects of various types, passing them between graspers, use of assistance as well. This is using a loop, which we actually teach them how to make themselves, so that they don't have to continually rely on borrowing them from hospitals or getting assistance from colleagues in industry. And we teach them to make their own loops for appendixes and for ectopics. This is a simple appendix model with the appendicular artery on the side of a water-filled glove, and the loop there is pre-tied themselves, and we do the exact same maneuvers and measures that take place during procedures. We don't claim that we're making the procedure exactly like it is in vivo, but the skills you will learn you will bring into your operating room, and that's what we keep repeating and keep emphasizing. This is suturing. This is, I suppose, for many, the step that everyone wants to get to, and this course will take most people all the way to suturing. And again, these are online lectures that we give in a stepwise fashion, and these can actually be changed such that you yourselves could be delivering the content if you wish. But at the moment, myself and Professor Prendeville are usually seen on many of the videos, or our voices are heard over those videos. So this, I suppose it's worth emphasizing the content. We upload content onto the website that people can use. These are just usually PDFs of relevant papers. We also have created the ability to record the training or record their individual best efforts at a different skill. And we've contemplated as to whether this could be used as a logbook. So if you slowly build up your skills and you record them, here is a logbook of your experience, and that could possibly be maintained for either interviews or for legal reasons later on in your career. In a country as big as Nigeria or a part of the world as large as West Africa, there is an opportunity to use distance learning as part of your curriculum development. This is showing candidates in London tuning into our course in Dublin, and this is something that we've been developing, and with modern technology it is possible to have a couple of centres around Nigeria or around West Africa tuning in to a central location, a central university location. And I think with your geography that may be something that might appeal to you. This is one of our websites. This shows the courses that are available on the front page, and individual students are given a username and a password, and they can log into the course and follow it month by month. So does it work? And I think this is often the question that we're often asked. Well, we studied one of our courses where we had 16 participants. We performed their baseline assessment on a virtual reality simulator, and we also performed assessments then on the Endosim simulator, and then we repeated those at the end of 6 months of training. All of the candidates completed this particular study, and there was a significant improvement in all metrics. And also the interesting thing was we found that they started to get closer and closer to each other. So there was a widespread initially, and you find that after 6 months that the skills or the various metrics start to come together. I think this is, for example, the path length to achieve a certain task, and you can see there's a widespread at the beginning of the course, but by the end of the course there's an economy of movement, the path lengths decrease. So this is something that we've shown and we've published on now, and these just are various graphs just showing that. We've also performed a randomized trial whereby we've had candidates taking home a simulator versus just running a day-long course, and we taught them how to basically suture in a day. Some were taking their simulators home, and some were just reassessed at 8 weeks. This just shows the flow of that. We had 25 in each group. They were taught to suture, as I said, in a day. They were given the equipment then to go home with, 25 of them, and they were brought back to assess. Now, this shows the highly significant difference between both groups at 8 weeks. Also, when we ask them to assess themselves with respect to time spent during the week, we find there's a linear relationship. So the more time you put in, the better your scores. So you can see the improvement. So if somebody only spends an hour a week, or 2 hours a week, they're down here, versus somebody that spends 4 or 5 hours a week, and they're much better with respect to improvement in time. But this is what it looks like. Initially, both groups are the same. After a day-long course, both groups are the same. But when you take a trainer home, you continue to improve with respect to the time to perform your skills, whereas it reduces or declines in those that have no simulator or ongoing training. And we've published on this, and there are several other papers going to be published on this. There's other ways of looking at how successful our course has been, and we've looked at our inpatient data on a national level, and we have found that between 2003 and 2010 there's been a large change in the way we deal with ectopic pregnancies. Almost 80% or more of women presenting to Irish hospitals in 2003 had a laparotomy for the management of their ectopics. That now has reduced down to only about 12%. Only 12% have a laparotomy now, and this is by you teaching this course. One of the things I think for you guys that might be interesting is that we would also emphasize the ability to perform a simple procedure like an ectopic pregnancy with reusable and very, very cost-effective equipment. So from a national level, from a Department of Health level, from a university hospital level, it makes sense not only to teach your trainees how to do this well and safely, but also how to do it cheaply. We are exploring other things. We're using tablets and motion sensing technology to further assess our trainees, but that's in the future for ourselves. So we think that our courses will lead to better credentialing of surgeons, better and improved licensing. Also, it's possible that our trainees that come through our courses will not have as high insurance premium to pay. And hopefully that this will become a European, and indeed we're hoping a worldwide standard with respect to laparoscopic skills training in gynecology and surgery. So it's a robust program. We feel that it's stepwise from A to Z. It's cost effective. It's portable and transportable. It can be run in many locations. You do not have to bring large stacks. The candidates bring the equipment with them. And in Ireland, certainly, it has had a national impact. I always disclose in my talks that I am a director of Endosim, and we hold patents that are related to the system. But I'm hoping that you've enjoyed the talk and that we look forward to meeting you next week in Dublin. Thank you very much.